Okay, so we are starting. So good evening, everyone. On behalf of Child Psychiatry Subcommittee of the Psychiatric Society of Western Zonal Branch, I warmly welcome all of our esteemed colleagues and participants to today's academic session on precision in pharmacological management of ADHD. ADHD is one of the most commonly encountered neurodevelopmental disorders in our clinical practice. And over the years, our understanding of ADHD has evolved tremendously. We have moved beyond a one size fits all approach and are increasingly recognizing that every child presents with a unique combination of symptoms, strengths, comorbidities, family factors, and environmental influences. So, this brings us to the concept of precision medicine, where treatment decisions are tailored to the individual child, aiming not only for symptom reduction, but also for optimal functioning, improved adherence, and better long term outcomes. So, in this era of rapidly expanding evidence and treatment options, understanding how to personalize pharmacological interventions has become more important than ever. So, to guide us through this clinically relevant topic, we are privileged to have with us Dr. Alka Subramaniam. Dr. Alka Subramaniam is a professor at Topiwala National Medical College and BYL Nair Charitable Hospital, Mumbai. She has over 25 years of rich clinical, academic, and research experience in psychiatry. She is a recipient of the prestigious Har Gobind Fellowship and received advanced exposure in child psychiatry and geriatric psychiatry at the State University of New York. She has been 1 minute lagegi Alka. Let people know. She has been instrumental in establishing pioneering services, including the LD Clinic, Autism Center, Remedial Center, Psychogeriatric Clinic, and more recently, Community Mental Health Services at Nair Hospital. On a personal note, I have known Dr. Alka since her residency days, and while our acquaintance was largely professional, it is truly gratifying to see a colleague psychiatrist grow into such a respected teacher, researcher, and leader in our field. Welcome, Dr. Alka, and we are really fortunate to have such an accomplished clinician, researcher, teacher like you with us today. So over to you, Dr. Alka.
Thank you so much, Khyati. I thought you would say that she's one of my oldest friends and we could start off with that. We go back a long way.
Yes, I've
So,
known you since the residency. That's what.
yes, we both were in residency around the same time. And thank you very much to the entire West Zone team for having me here today. Mishra ji personally wished me yesterday and said that he would see us here. So thank you, President Sir. And of course, Manjari, who coordinated, Neha and Swati, I think, who did all the background work, and Khyati is the EC coordinator, along with the entire committee. I'm not reading all your names, but thank you very, very much for having this and for accommodating the change in dates, because I had some personal reasons why I couldn't have it. We were supposed to have this session in March, actually. So thank you for being so gracious and actually getting that done. So today we are going to be speaking over the next hour or so on precision in the pharmacological treatment of ADHD. And let me just start sharing my screen. And can you see that? Is it clear?
Yes, ma'am.
Yes.
All right. Okay, so now even before I go on, what do you think you understand about precision in the pharmacological management? Please put it into the chat box so that we all can kind of understand. We're going to make this interactive. You know, I usually do. So let's quickly start typing in as far as we possibly can. So what is your understanding of when we say precision treatment or precision pharmacological management? What really do you think we are aiming towards today? Okay, best choice of drug, more specific, personalized. Anybody else? tailored and adjusted. Okay. Anything else? Why precision? Personalized, tailor-made dose and choice of drugs. All right. So I am assuming from all this, I understand that we have precision is when the drug is suited for some specific cause or symptoms, is it? All right, all right, all right. That question now, let's go on to the next this thing. So I'm assuming from that, okay, I don't know how this goes forward, that all of you here today have a fairly good idea about diagnosing ADHD. Do any of you have a problem, or any of you have doubts or questions about how to fundamentally diagnose a case of pure ADHD if you were to get it? Is there a consensus on confidence that you can do that? If there isn't, please put your query in the chat box. Okay, so precision in managing symptoms, very good. So we at least know where we are headed in terms of an aim of the talk. But anybody have any doubts about ADHD? Would you worry if, forget the comorbidities, let's forget the side effects, forget all of that. Right now, if you get a classical case, do you have any doubts in understanding or diagnosing ADHD? So since there are no doubts, I'm assuming that we go ahead and we figure it out, right? So what is ADHD really? What is happening at the brain level and what is happening in terms of domains? What are we looking at? When you look at a child, we're not going to talk about adults today. We'll do that maybe some other time if we need to. Today, it's going to be all about children and adolescents. So when a child or adolescent comes to you and you see or you think that this is ADHD, what are you thinking is happening in the brain and what are you thinking in terms of domains? Please quickly write your answers. Okay, that decided to shift on its own. Never mind. So we do know that the ADHD has the ADHD syndrome or the ADHD spectrum definitely does have a genetic predisposition, but there are so many epigenetic factors which play a role in it, right? So you have an imbalance which is sort of ubiquitous, and it is because of this imbalance that we kind of have so much of overlap of various disorders and the comorbidities. So the domains that I was speaking about are your three core features, which is namely inattention, hyperactivity, and impulsivity, right? All right. So now let's try and go through what we can do whenever we get a case of ADHD. First, tell me which agents are available for use for ADHD in India. Which drugs? That should be simple. Which molecules are available for use for treatment of ADHD in India? Methylphenidate, MDET. I like that. Okay. Perfect. Perfect. So we have basically, it's one of the smallest cachet of drugs that we have compared to any other disorder, to be very honest. So it's not too difficult provided we understand how to juggle these drugs, right? So methylphenidate, all the preparations, atomoxetine and clonidine by and large. What we don't have is guanfacine and viloxazine. And then, of course, your additionals, which is risperidone, aripiprazole, bupropion, nutraceuticals, so on and so forth, right? So now let us look through some prototypes and try and understand how we are going to approach it and see if we are actually reaching a consensus in whatever we are saying to each other. Okay. Why did that happen? All right. So here you have a prototype. 8-year-old boy constantly out of his seat, interrupting class and is disruptive. What would be the drug of choice? Let's assume that we have ruled out all the other history. I didn't go into longer histories today. I said, let's just go to prototypes because we want to see how we can help tailor things specifically today. So MPH, is that a given? Yes. So what are we really dealing with in terms of circuitry? All right. So you have the dopamine circuits, there's motor restlessness, there's impulsivity, risk-taking, so behavior dyscontrol. So what we give first line, gold standard is methylphenidate. And if not tolerant, if otherwise there are problems, then you would think of atomoxetine. The usual problem is that the assumption that the behavior may be purely oppositional and we shouldn't fall for that. Also, the response, clinical response is important for us to understand and go ahead with, okay? So the next one is a 12-year-old student who is forgetful, disorganized, and daydreams. Prototype for what would you treat with? What would you treat with? Atomoxetine, all right. Anybody else? Methylphenidate, okay. Anybody else? Why? Okay, since there are two different schools of thought, I'm going to ask those who said methylphenidate, why methylphenidate, and those who said atomoxetine, why atomoxetine? Quickly. MPH because it's first line, all right. Atomoxetine, why? Someone has written both. Inattention predominant, all right. Okay, so actually, the first line is yet a stimulant when we are talking about an executive dysfunctioning circuit, right? So therefore, it becomes important for us to actually understand what are the broad phenotypes we are dealing with. Very often we misunderstand and we construe that inattention predominant is equivalent to or equals to use of atomoxetine. What we have to remember is that when we are talking about the dopamine affected circuits, which includes executive dysfunction, distractibility, boredom, underarousal, or reward seeking, okay, the prototype being hyperactive, impulsive, or inattentive because of the dopamine circuit affected, methylphenidate yet continues to be the drug of choice first. On the other hand, when you're talking about the noradrenergic dysregulation, which includes anxiety, rumination, overthinking, which is a symptom which I don't think we ask often enough to a child, right? Emotional sensitivity or emotional lability and autism overlap. That time we are talking about a prototype of emotional dysregulation, anxiety, or at times rejection sensitivity, which is to be treated with atomoxetine most of the time. Third prototype is, of course, the impulse control, where there is a hyperarousal state, and what we want is calming. So when there are disturbances in sleep, when there's extremely high impulsivity, and that may manifest in with aggression or motor tics, then or even vocal tics, then what we want is the calming effect, and that's where the clonidine comes in. Are we on the same page so far? Right? So let's look at some more prototypes now. Now you have an 11-year-old perfectionist child with excessive worries and poor concentration. Now tell me what you would choose. Okay, for some reason, this chat box keeps disappearing for me. Oops, sorry. Yes, right. Perfect. So we are getting there. Are we clear now? Because you were able to understand that the domain told you that we are dealing with the noradrenergic circuit, and I would want to first try atomoxetine above anything else in order to see what is sort of working out here. Correct? Yeah. So even when I have anxiety as a predominant symptom, what I need to do is first try to see if the atomoxetine takes care of both aspects of it rather than add on an antidepressant or add on something for the anxiety. See if atomoxetine, which is working on the circuit concern, is taking care of that. All right. So we go on to the next one. So there is a young child who has frequent meltdowns, forget the age, irritability, and severe reactions to frustration. Now, what would be the drug of choice? Okay, very good. Because why clonidine? Why clonidine? So irritability and emotional lability, to differentiate between high impulsivity and emotional dysregulation is what we have to do here. So clonidine could be one, but we could have gone with atomoxetine yet because it was more of the tantrums and irritability. If there is more impulsivity, then I'm going to think of clonidine. We will come to that later, right? So emotional dysregulation, again, think of the circuit. The circuit is yet the noradrenergic circuit. So keep that in mind. We again think of how we can approach that once we do this lot. Okay. Then there's a teenager who is absolutely devastated by the criticism and is socially overreactive. So again, what are we dealing with here? When you become very reactive to criticism, what is it called? What is it called? Rejection sensitivity or hypersensitivity, right? So therefore, your drug of choice becomes, again, atomoxetine. Are we seeing the pattern here? Are we seeing the pattern where you were very clear earlier when the dopamine circuits were involved, how you're choosing methylphenidate? Here, I have other symptomatology and presentations, but the circuits involved are the noradrenergic circuits. So what is my drug of choice coming back again and again as atomoxetine, right? Okay, so over here, be very careful that we don't, in all three, we have to be very careful that we do not only term it as anxiety or depression or emotional lability and immediately add on the antidepressant or the anti-anxiety pill. First, try with atomoxetine and see how much of symptom control we are getting, right? So rejection sensitivity, that's how we met. So again, coming back to this, because somewhere we got lost with clonidine. So impulsivity and the hyperarousal, we sometimes have to differentiate between emotional lability vis-a-vis high impulsivity. Go back in the history. Go back and try and see, is this what I'm really dealing with? Now let's go on to a little more layered cases. So you have a child with sensory sensitivities, rigidity, and ADHD symptoms. Tell me now. Yeah, Radhika, we'll answer your questions in the end, right? Because you'll come to it. I'll tell you how we'll differentiate between anxiety and depression. Okay, no, before you tell me the drug, now that we are sticking to molecules, what do you think, first of all, the child has? Sensory sensitivities, rigidity, and ADHD symptoms? Yeah, possible. There's a possibility of ASD. And what would we want to give over here? atomoxetine. Here is where you could possibly think of clonidine or melatonin. And although I am not very fond of giving methylphenidate in patients with a neurodevelopmental overlap, it's not contraindicated and it's not prohibited. So if you can be very wary of it, sometimes dopamine causes severe activation and you have to be a little careful about those who are already on the sensory spectrum. When they have sensory impairments or sensitivities which are already in a hyperarousal state, that time then the MPH can cause a little bit of an issue. So we have to be a little wary of that. Therefore, atomoxetine, melatonin, these things work really well. An adolescent with novelty seeking and emerging substance use. Which circuit? First think of which circuit we are dealing with, and then think of the molecule. Three things: dopamine, noradrenergic, and the hyperarousal impulsivity. Now, okay, so, right. So even if it's dopamine, if you were to use MPH here, which again is not contraindicated, what are you going to be worried about? What is the one thing you have to? Yes. So we don't call it addiction. It may be dependence. It could be partial dependence. But basically, we have to worry about excessive overuse of this individual. Why? Why? Why are we worried about this individual having excessive dependence? What is there in the profile? What is affected? What is the dominant circuit? Yes, dopamine, novelty seeking, but the reward pathway is already affected, correct? So the reward pathway is already affected, and you are giving something which is going to further stimulate that reward pathway. So that's a big risk. So therefore, if we have to give methylphenidate, what type of methylphenidate would we give? We would give the extended release. Why the extended release? Because in extended release, the hit is not, it's not like a spike where you have a hit and run, right? It's a smaller plateau. So I do want to give methylphenidate. You're absolutely right. Dopamine, novelty seeking, reward pathway. I want to give methylphenidate. At the same time, I want to protect myself as the practitioner. Plus, I want to protect the patient and see that there is no emergent iatrogenic dependence, right? And therefore, I have to keep that in mind. Or if I find that there is a seeking behavior for increased dosing, they will keep coming back and saying that I'm not comfortable. Can you give me a higher dose? I'm not comfortable. Can you give me a higher dose? Right? So in that case, then you would think of atomoxetine. Yes, so all of these cases would have differentials because we're just putting prototypes. We're not discussed the case in detail, but we'll come to all your questions at a later date, later time over here. Okay. So the misuse risk is what we need to keep in mind. And of course, access. Keep that very, very much in mind. All right. Next. So someone who is impulsively snacking or eating excessively with ADHD. Now you could replace that impulsive snacking with excessive mobile use, with excessive reckless behavior, with excessive sexual behavior, so on and so forth. So which circuit? Which circuit? Again, this is reward dysregulation, right? Because you're in a loop where you're trying to get instant gratification. It is very, very important that we understand this instant gratification, usually the reward circuitry, usually dopamine, correct? And therefore, to snip it, I need the stimulant. In this case, how will the stimulant additionally help us, particularly for impulsive binge eating? which is why I put this and not the mobile use. What is going to be an offshoot which is going to be clinically useful for us? Correct. The decreased appetite is something that we want. We do not want there to be a cued reaction or an attraction to food. So we use that as a offshoot, correct? But now supposing this was replaced with excessive mobile use or impulsive mobile use, supposing it was with reckless driving, supposing it was with reckless sexual activity, would you change your mind? What would you want? Definitely MPH stays. Okay, that would still be one of the things that would be on our radar for a drug of choice. Anything else? Yeah, naltrexone, yes, Ritvik, but apart from naltrexone, something else. So we are not going, we are discussing the three molecules basic for ADHD, and we are going to stick to those three. Clonidine. So here I want a calming effect, and that's where I would choose possibly clonidine if I find the impulsivity very high, right? Okay, all right. So we go to the next. So that's any binge or any excessive use. Now let's approach this molecule by molecule. What is the gold standard for ADHD treatment across the globe? No doubts about it, right? No doubts about MPH? All right. Tell me, what are the commonest side effects of MPH, that methylphenidate, that we are really worried about, and how do we manage them? Because that, unless we manage that, the patients are not going to come back to us. And very often they don't want to come back because of this. Reduced appetite, okay. What else? Growth suppression, nausea, tics, insomnia. Yes, yes, right. So I think you guys are very, very clever people. Drug holiday is a side effect. All right. So appetite suppression, one of the commonest things that we are constantly worried about, and our patients come back again and again and again, more so with the immediate release preparations. So good breakfast is very important. Our schools start very early in the morning, right? And it becomes very difficult for children to really have that good breakfast. So how do we manage it? They say, I can't stomach so much. My mother wants to give me uh, eggs, or wants to give me a sandwich or a paratha and chapati bhaji, and it's not possible in the morning. Heavy dinner is okay, but we need something before you give them. You usually give them methylphenidate in the morning, don't you? Yes or no? Give it in tiffin. Okay. Would you give it in the tiffin, really? What would you advise for breakfast? Let me repeat my question very clearly. What would you advise for breakfast? Early morning when they can't have a heavy breakfast. I'm sorry, I don't know your first name, AP Singh. I don't want to eat eggs. I don't want to have that. Which foods are easier to swallow? You're getting there, Nandita. So you want proteins and you want something very easy, which just children gulp down. Correct. So you make a milk smoothie, right? You put in banana, you put in nuts, you put in milkshakes. If you can put in the egg, blend it into a smoothie and give it, good for the mom, good for the child. Take that, they're good for the day. Child is probably not going to eat till 4 o'clock. No matter what you try, tell the parents, forget about lunch. When we start this, Don't bother about the fact that your child can't eat lunch, but when they come back by 4 or 5, make sure that they have something calorie dense ready because they'll be starving. The rebound which comes at that time is very, very bad. So we need to keep that in mind. Okay, clear. So don't force them to have the eggs and the parathas and the puri bhaji and all that stuff. If they can't have it, the smoothie with the milk, so that takes care of the protein, that takes care of the nutrients, at least for a long part of the day, because believe me, till 4 o'clock, they're not going to want to see food again. It really suppresses the appetite. And if they can't even eat that, then we need to give them something along with that. What do we give to stimulate the appetite? What do we give? Come on. What do you all give to stimulate the appetite? What is activate is okay. Cyproheptadine, correct. All right. Next, you said insomnia, headache, GI symptoms. So, particularly with insomnia, we need to see that the dosing strategy is maintained. Parents will tell you that they're giving it not after 4 o'clock or they're giving it early in the morning, and you'd find that it's going in the tiffin, like someone said, and therefore the child is taking it at 10, 11, and then the child cannot sleep. So please check the dosing timing as well as exactly when and how the child is having it. Late boosters should be avoided. Of course, you can always complement with melatonin if required. As far as headache is concerned, hydration is the most important key. What we find is that when appetite gets suppressed, drinking of water also significantly goes down. So once we start monitoring water intake and we increase hydration, automatically the headache sort of goes down or peters down. Once you change dosing and you ask them to keep a diary or monitor when the dosing is supposed to be kept, suddenly you find that the sleep also takes care of itself. So the documentation and the maintenance of what happens or how the parent or the family is managing the ADHD medicine becomes very, very important for us. The third thing you all said, or perhaps didn't say, was anxiety, emotional blunting, and of course, emotional numbing. A lot of parents come back to us and say, I don't want to give this to my child. My bubbly child who used to be all over the place, yes, that time was considered Dennis the Menace, has become like a zombie now. We do not want to make children zombies. The aim of the medication is not to make the children zombies. So, first, you can always reduce the dose, titrate it downwards, and see how the child is doing. If the child is yet not doing so, first, when they come to you, it's important for us to always tell the parent, I am starting with the bare minimum dose. I'm going to see the effects and the side effects, and this titration is going to take us 4 to 6 weeks. So please don't think that we can just abandon the medication right in the beginning, right? And usually we tell them to come back to us whenever they feel this zombie-like state. So it's a good idea to preempt them about it, because when they suddenly see this absolute Dennis the Menace becoming this absolute quiet little child, they are not comfortable with it. They think that we have given them something which is going to make the child zonked forever, right? So we have to figure that out and probably change the dose. Not necessarily stop the medication, but change the dose. Then, of course, tics. So tics, sometimes rebound irritability could be mistaken for tics, and sometimes there's a predisposition for tics. So it's very important to understand that if the wear off effect is happening fast, then you change the formulation and do not label it only as a tic. How do we do that? Is that you can actually check and see by changing the formulation whether it's persisting or whether it's going down. Of course, we do a whole neuro workup. We do everything to see that we have ruled out a tic disorder if you so think so. But if you find, particularly when you're asking about the wear off effect, ask if that's the time when you are seeing the movements either or the vocalizations, and try and see if you need a change in the dosing strategy. Okay. All right. So If you have someone who comes with ADHD and motor or vocal tics which are causing distress, how are we going to approach it? With what? Again, let's go back to circuits. Let's go back to side effects and let's see what are we going to do. Yes, so the first drug of choice is clonidine, but sometimes clonidine does not work very well for ADHD. So though you have things like naltrexone and others which have already been mentioned, I often feel that it's good to go back to methylphenidate if needed and use a combinations. Do not avoid stimulants completely. Let's not be scared of prescribing a stimulant because A, we have diagnosed correctly or otherwise tics, and if they can be managed along with it, then probably a collaborative work with neuro does help. So cautious use of stimulant is indicated even with tics. All right. What about delayed sleep onset? You've done everything, but there are issues. What would you do? Clonidine, early dosing, yes, very good. Melatonin, okay. What else? So it's also very important to go back into the history whenever you have a sleep issue to figure out about sleep hygiene. And we had this case very recently where the teacher came to us and said the child is always sleeping in the first three periods. And we went back and said, what is the child on? And she said, methylphenidate. We said, how is it possible that with methylphenidate, any child can sleep? So it turns out to be that the parents were daily wage workers. So he would sleep at 1 o'clock every day, come to school, and he was told to have a heavy breakfast and then take his tablet. So he would sleep for the first three periods, have his heavy breakfast, take the tablet in school, and then be fine, and then again be awake. So going back and forth in the history becomes very important for us. And melatonin, yes, clonidine. Sometimes you can even use atomoxetine because you know that one of the side effects at times of atomoxetine, and we'll be coming to that, is sleep. So we can use that for helping with the circadian rhythm, which often is intrinsically not okay in children with ADHD. Okay, so they already have, apart from the dopamine and the noradrenergic system affected, you would have the sleep cycle affected intrinsically as part and parcel of their whole spectrum of the ADHD. So y'all were bang on that, except atomoxetine was sort of left out. All right. Now you would think which formulation? When do I use immediate release? When do I use sustained release? And when do I use extended release? Tell me, what are your thoughts? Let's go with immediate release first. When do we use immediate release methylphenidate? Come on. Mild ADHD when concentration is required while initiating. Okay. So the first thing you would ever prescribe would be immediate release. Is that what you're saying, Vidushi? Okay. Symptoms are severe, exams, all right. Okay. Anybody else? Immediate release. Start with IR, switch to SR while initiating and evening. What is that? Booster. Okay, what is a booster? This is new terminology for me. Predominant inattention. I would use immediate release. Okay. All right. Okay. Let's see. Then when would you use sustained release? SR, when would you use sustained release formulations? Come on. In addition to IR, when I require effect for 5 to 6, when there are side effects, okay. Only when there are side effects, I'm going to use SR preparation. Okay. And when do I use ER preparation? Extended release. And now I believe there's a company coming out with OROS also. Coverage needed from morning to afternoon is for what? SR or for ER? Full day coverage. So who needs full day coverage? All right, all right. I think we have discussed enough. Let's try and understand this. Okay. Immediate release preparations are usually the most flexible when we are doing titration. To be very honest, I hardly use immediate release anymore because I find the rebound is just way too much and the appetite suppression is really, really high. So we go nowadays at Nair, most of the time we go straight to 10 SR preparation because you get a slower curve of improvement, but at least it's not a spike in terms of the improvement of symptoms and then the sudden rebound and severe irritability, severe appetite suppression. But in transitions, we add the 5 or the 10 SR when we want to transition. So SR preparation works really well during school days because it's covering how many hours? How many hours? Type, please. Correct. So about anywhere between that 4 to 6, 7 hours. And what about ER? ER covers how long? Correct. So they say 12, but I think it's about 8 to 10 hours. It doesn't cover so much. So for older children, ER is good for us because we don't have guanfacine. Actually, typically for an adolescent, guanfacine works really, really well, but we are waiting for it. I've been hounding companies to get it, but we have some regulatory issues. So what we have to remember is, are we giving too much to zombify the patient, as the parents say, or is it wearing off too fast? And are you getting the irritability? Are you getting the side effects which are coming in? So typifying this is what actually resolves your issue, whether you should give IR, SR, or ER. Usually, it's safe enough to start with a sustained release preparation. Whenever you're doing drug titration and increasing doses, that's when you can introduce your, so you will say 10 SR, add 5 IR, go quickly to 20 SR. Again, when you want to increase, add another 5 or 10 IR and then go quickly because you don't want that effect to last too long where you get the rebound and you get the appetite suppression. Are we clear? And then you go from there to the extended release, and then in extended release, you kind of titrate the dose upwards from 18 to 36 to 54. So that's how we would choose if we want to get into methylphenidate. Are we on the same page so far? So we have seen prototypes, we have seen the 3 circuits, and we have seen methylphenidate as a molecule. We now go to atomoxetine. Tell me very quickly, SR versus ER. ER is usually when you realize that during the day, the wear off effect is happening much more despite you giving a higher dose during the SR, you switch over to ER. So for example, if I am already given 20 and I'm going to 40 SR and I find yet the wear off effect is there, I'd rather switch to an ER preparation. All right. Okay, now we come to atomoxetine. Tell me side effects of atomoxetine, common things that you all encounter. One we already discussed in one of the case vignettes earlier. I'm going to overshoot 9:30 a little bit because I have tried to cover everything. So if y'all are okay with that and you can bear with me, we could do that. Sedation, hepatotoxic, nausea, abdominal pain. Okay. So one of the commonest thing is having stomach ache after starting, nausea, abdominal pain, or dyspepsia. So the best thing is to give it after meals. We do give something like pantoprazole or esomeprazole in the initial 2 weeks or 10 days till they settle down, because it's a tolerance curve and usually it disappears within 2 to 4 weeks. But giving it after meals really helps take care of the GI symptoms. So this is something we have to reinforce again and again and again to the parent. Do not stop the medication unless the nausea is absolutely debilitating. Usually by giving something to counter it, it takes care of the symptoms in children, right? Very peculiarly, atomoxetine can cause both somnolence or insomnia. So the best way to deal with a sleep disturbance, if it is insomnia, what will you do? You'll give the dose in the morning. And if it is someone who is sleeping in class or starts nodding off in class, best is to give it at night. And that works really well because they eat their dinner, they take the medicine and they go to sleep. So it takes care of the nausea also, right? But if you get rebound insomnia, then you can't give such a child the dose in the night. So that's what we have to keep in mind. This is another peculiar side effect with atomoxetine, where we often have references saying that there is a switch with atomoxetine, and so is the child pediatric bipolar. Please, let's not just jump and make, 2 plus 2 is equal to 22. It doesn't work that way. So the worsening of the mood or emotional reactivity, whether it is occurring only which is dose related, first of all. Number two, are there any pre-existing symptoms which are there? Is there a persistence? So someone was asking, how do we differentiate between anxiety and depression, and whether the irritability or the emotional changes are with the ADHD or with the medication? So the consistency of the symptoms is very important. The response to treatment is equally important. So if I find a child who has persistence of symptomatology despite all my efforts, right, of treatment, and these are the symptoms which continue, then I'm going to have to think of a comorbidity. On the other hand, if this is something which fluctuates, it comes and goes, it could be inherently a part of the ADHD. If I am finding in my chronological history that every time this changes with the medication, you'll have to excuse me for a minute. Just a minute. Is it? I'm sorry. Yeah. So if you find that with relation to the drug dosing, I'm getting the change in the mood or the change in the affect, that's the time when I'm going to try and see if this is drug related, dose related, and titrate that. Are we clear so far? All right. So with atomoxetine, you have to really be very vigilant for very subtle side effects. Then, of course, tachycardia is one of the things which often happens and is very worrisome, but it may not be something which is persistent. It could be transient. And in general, so we didn't mention this in with methylphenidate, and I thought you all would, that there are many who come and complain of tachycardia. So it really helps giving the child one of those child watches, which is there to see, for the parents to actually objectively see that these are transient and they do disappear. And it doesn't usually go beyond the physiological upper limit of when they are playing sports too. So that's how we kind of correlate for them. And that transient change usually comes down over a period of time. We'll also come to how to deal with it using relaxation techniques, right? And of course, rarely you might have suicidal thoughts. Somebody mentioned liver injury and urinary symptoms. So we need to monitor this at every time when they do come, and intermittently do a entire workup to see that we are not missing out on anything in terms of the labs or the bloods. And finally is clonidine. So quickly, can you tell me now, what are the side effects of clonidine that you all know about? Constipation, sedation, hypotension, all right, orthostatic. So the thing that we are worried about most is the hypotension, but sedation and daytime sleepiness is genuinely a concern, and therefore giving clonidine in the morning really doesn't work. But we can use this to our advantage. And when can we use this to our advantage? The sedation that is caused by clonidine. When do we use it to our advantage? What do you mean by night? For insomnia with methylphenidate. Excellent. So when we have a persistent problem with insomnia, which is not going away with any of the things that we discussed, keep this in mind, right? Of course, dizziness and hypotension is very important. There are many studies which have actually shown that psychiatrists are very worried about prescribing clonidine vis-a-vis pediatricians, who are more comfortable because they usually monitor the pulse, BP, hydration, so on and so forth. So if one makes it a practice to monitor and tell the parents about that too, then it doesn't become so much of an issue. Number two, orthostatic hypotension is actually with change of position. So we need to teach the child, teach the parents that whenever you're changing from one position to the other, please maintain from lying down to sitting, from sitting to standing, like we do with our elder individuals, right? And you keep that 30 seconds in between so that you don't feel the sudden change in dizziness and you don't get that. And the third thing is, of course, you can teach techniques like JPMR and basically diaphragmatic breathing, which increases vagal tone, and therefore that sort of takes care of the dizziness. Irritability can also happen, and we've discussed this at length with atomoxetine. So try and figure out whether it's the ADHD, whether it's another disorder, or whether it is drug related. Sleep, we did, and rebound hypertension. So cardiovascular problems are some things that we need to be very, very vigilant of and monitor regularly, which I don't think we do as much as we should be doing. A problem with clonidine is abrupt cessation or withdrawal with the withdrawal symptoms, and there can be severe agitation, tachycardia, and headache, which the family comes with. So when they come to you in an acute stage stating that, please keep in mind or keep thinking that have they suddenly stopped clonidine? Did they go on a holiday and they forgot to take it? Did they happen to go elsewhere and the dose got over, so on and so forth, these combinations, so that they can be told that you cannot do that with the drug. It really causes a problem. All right. So when we look at an overview, we are looking at whether we are dealing with comorbidity and how would I really approach that comorbidity through non-stimulants, or do I need to give a stimulant, and then whether it's short, intermediate, or long acting, right? And of course, we know that ADHD, today we're doing precision in psychopharmacology, but we know that ADHD is way beyond that. And there are non-pharmacological methods. There are, of course, there's a whole host of things which talk about epigenetic influences, which I'm not going to go into because these have very low evidence-based diets, food colors, etc. And now we have computer-based training, and we know that there is a first FDA-approved game for ADHD. So this is actually an overview. But how do we really rationalize use? When I have treated with all this, okay, so I've given either MPH or I've given atomoxetine, I've given clonidine. When do I say that it's not working? I need to do something more. And how do I approach that? When do I actually take this call? Any thoughts? Any thoughts? When do I say that it's not working? I need to do something more. Come on. I have given either of the three medications and I think that the child is not getting better. What do I do? Review diagnosis, check for comorbidities, non-pharmacological methods, have side effects, adherence, very good. We always start with monotherapy, right? So we will check all those things and we will also talk about that a little later. But when do I think of combinations? Do I ever combine drugs? And when should I combine? Partial response when one drug has been tied to maximum dosing. Okay. When will I give methylphenidate and atomoxetine together? Let's go straight into that. When would I give MPH and atomoxetine? What would be the clinical profile, or what else would I want to look at? Okay, higher doses of MPH not tolerated. What else? Continued concentration. Okay. When I need very good. Anxiety, social anxiety, insomnia, or broader attention. Now, I have given, say, 36 or 54 milligrams of methylphenidate extended release. And this is a college student or someone appearing for NEET who says that I have a wear-off effect by 4 or 5 or 6 o'clock, and I really need those excessive 4 hours. Will you give an IR methylphenidate along with that? No. That is when I would think, let me combine and let me have a synergistic or an additive effect. So combinations are usually need-based. It comes from the end user that I am needing this and therefore please give me something to get better. So, or I am having too many ups and downs as far as my emotional regulation is concerned. So please do something about it. Now, what about methylphenidate and clonidine? Only sleep? Anything else? Impulsivity, tics. All right. Let's have a look. Particularly when you have high impulsivity or you have persistent sleep problems, it's unfortunately one of the lesser used combinations, but over the years, I have found that it's extremely useful in management of overall ADHD. The combination of methylphenidate and clonidine seems to somehow take care of a lot of symptoms as well as give rest, which works very well. And probably because of the intrinsic adrenergic action that it has, there's also not a direct effect, but somehow the acceptance of the morning breakfast increases and is a little better. So methylphenidate and clonidine is probably something which we should really be using a little more often that we aren't using. The core impulsivity also gets taken care of, apart from the fact that you may have a person with high impulse control or dysregulation. So those who are taking ER preparations and maybe in school or in early college at times find delayed sleep onset because anyways the adolescent brain has now shifted phase. These are the kind of individuals where your clonidine will work really well because it takes care of that, even the adolescent impulsivity which is emerging at that point in time. Not that we're trying to suppress it, but it just takes care of it from a neurophysiological point of view. What about atomoxetine and clonidine? Would we use it? Ticks on MPH. Okay. What else? What circuit did we talk about for atomoxetine? Noradrenergic, right? And hyperarousal for clonidine, right? So atomoxetine, we said, is for anxiety, for emotional changes, clonidine for impulsivity or emotional dysregulation. So we want this to be used, the combination to use when we want a lot of calming to take place, right? Sorry, how did that go back there? For some reason, this isn't working. Okay. Anyways, so basically, it is when we want, when we have anxiety or when we have associated emotional dysregulation and you want increased calming, that's when the atomoxetine needs to be used along with the clonidine. So takes care of both of them, and there is regulation of sleep, regulation of the turbulence which is there. So cardiovascular monitoring across all three becomes very important because methylphenidate we know causes slight increase along with atomoxetine, which is the converse for clonidine. What is the red flag for us is when you have something like syncope, arrhythmia, or a pre-existing cardiac disease, in which case I would strongly advise to take a clearance before you really start the medication. So monitoring is important from a physiological perspective, not that we think everything is pathology just because of our lack of knowledge. And that's why I say that again, the smartwatches really help us with the monitoring. And nowadays, a lot of children are okay with wearing them. So to reiterate, the previous slide was basically for anxiety or emotional dysregulation. For some reason, it's not working over here. So I've put it down any which ways as a combination. So when we want a broader attention span or the high yield, when we say that there are high intense or high yield courses where the child needs that kind of thing, we use a combination of methylphenidate and atomoxetine. Sleep issues is where the clonidine comes in, and when we want a calming effect is when we have atomoxetine and clonidine. Do you use all three together? I would not recommend it. I would seriously not recommend it, and I would think that anyone who's trying that should be very wary, because we do not have any backup in terms of evidence base, and it's a little bit of a risk to take if you're going to use the combination of all. All right. So, of course, we've also got risperidone, which we use mainly. Where do we use risperidone? Do we use it for core ADHD? With intellectual disability? Okay. What do we use risperidone for? Aggression. Okay. And ASD. Correct. So we used to use risperidone a lot earlier in ADHD when we were not so comfortable using methylphenidate. Now, over the period of years with the acceptance, antipsychotics are not anymore the drug of choice, right? So aggression can be managed with other measures rather than using risperidone. In younger children, it used to be the norm, right? Children under 5 years. Today, even children under 5 years, if the degree of hyperactivity is so much, a trial of methylphenidate can be done. So there are studies today who talk about 3 to 5 year old children with severe impairment in sustained attention or with high motor activity who can be given a trial of methylphenidate. Start with the lowest dose available, and this is the place where actually we use the immediate release preparation, because we don't want such a young child to necessarily pay attention for a longer period of time. And quite surprisingly, for the first time in guidelines, it's actually come that antipsychotics are contraindicated because we don't have that much of data about safety, long-term safety data and efficacy. So of course, we talk about ADHD non-pharmacological methods for 5 years and younger, but you can consider starting medication when those have failed. If the child is very disruptive, very hyperactive, then do consider methylphenidate and nothing else. Apart from risperidone, aripiprazole, which again is used for dysregulation or emotional dysregulation, but usually used again with which comorbidity? Which comorbidity do we use aripiprazole with? ASD. And if we use an AED or a mood stabilizer, as they're called, an anti-epileptic, usually carbamazepine, oxcarbazepine, what do we use it for? When you have emotional dysregulation or behavioral disturbances with, okay, ODD, what else? Something where it may not be a disorder of behavior per se. It is behavioral disturbances associated with something which is neurodevelopmental. Intellectual disability, excellent. So that's where you would want to think of using your carbamazepine or oxcarbazepine. A lot of questions are often asked about nutritional approaches and omega-3 fatty acids. I'm not sure whether the evidence base has yet come up to a level where we can say that we could prescribe it as an adjuvant. What we can safely say is that addition of omega-3 in the diet, like through walnuts, etc., is good overall. Do we need to really spend a lot of money on high-end omega-3 fatty acids? I'm not yet convinced about that. So the jury is not yet out on this one. Some people really feel that omega-3 makes a huge difference. And I'm sure in younger children, any omega-3 would make a difference because it does have the phytochemicals which really help. But we don't have evidence enough. Again, NAC, L-carnosine, do they really work in social communication? A subset of patients definitely do respond to L-carnosine, but those are the ones which have metabolic syndromes. Have we been able to identify filters so that I can tell you that this subset is whom you should give? No. Should you just blanketly give to everybody who has ASD or ADHD? I would not think so. So let's just wait for more research to come and don't let our patients spend more money than they really necessarily have to. Memantine is something which we have experience about. I don't know where those two ticks came from. And we have been using this across neurodevelopmental disorders just because the glutamatergic effects or the glutamatergic neurodevelopmental theories and responses are increasingly coming up now as evidence, right? And across the board, whether it is ID, whether it is ADHD, whether it is autism, we find that the excitotoxicity to reduce really helps over a long period of time, and the penetrance of other molecules possibly really helps. So this is something which maybe if you want to experiment, you can. We have been doing it in a fair number of patients, and we have found as an adjunct. It cannot be monotherapy, but we have found as an adjunct, it helps with low doses like 5 milligrams or 10 milligrams, right? So if we have to put this all together, what becomes important in ADHD, like you all said, is the functional impairment. Identify which is the dominant phenotype and which domain are we talking about. Is there executive dysfunction? Are we talking about a non-adrenergic pathway? Is it the reward pathway? Are there sleep problems? Is there hyperarousal? So on and so forth. So am I dealing with methylphenidate, atomoxetine, clonidine? What about the adjuncts? And how do I therefore decide my medication? So the chief question is that should I switch or should I combine? And that's where we just discussed how do we want to really combine, and if I have to switch, when would I switch? So if I really think that there is a non-response, how do I go about it? Is there something like resistance in ADHD? Is there something like non-responsiveness? Could I ever say that? Yes, no, and why? Would you say that there are some children who are non-responsive or they have resistant ADHD? Have you ever heard of this kind of a term? Tachyphylaxis. Very good, Karishma. Yes. So we have fast metabolizers. What else? Yes or no? Have you ever heard of this term? Have you ever thought that, this child is just not responding? What do we do? So when you don't have a clear-cut diagnosis, you might think that because of that spectral overlap, that it is treatment resistance, but we don't really call it treatment resistance nor non-responsiveness. What we need to really look at, if you call it resistance, is reconfirm the diagnosis, find out your dominant phenotype again, optimize the line of treatment, and consider the rational combinations, again, measuring functionality and not symptomatology. So relook, have you missed out anxiety, autism, ODH, or OCD, depression? So I think Dr. Radhika was asking. So this is where that despite persistence of treatment, regularity of treatment, despite adherence, yet there are emergent symptoms. That's when I would think of a comorbid diagnosis, right? Don't assume that all inattention is because of ADHD. Have you given an adequate dose for an adequate number of time? Is it that drug holidays were prescribed? In today's day and age, honestly, most of the literature says that the growth suppression is not so severe that we have to give drug holidays at all, because ADHD is not only about schooling, it's about their social interactions and life in general. So we do not give drug holidays. We actually let them continue with lifestyle measures so that we can enhance the neurodevelopmental trajectory and prevent whatever problems can happen with untreated ADHD. Look at the adherence, see the weekend breaks. Are they happening more often? Is it becoming Friday and Monday break? I don't give weekend breaks. None of us prescribe weekend breaks, and we have stopped giving school holidays too, most of the time, right? So check for adherence. Look at what is really causing the impairment. Is it, like Khyati said in the middle, are there some environmental factors? Is it the schooling? Is there bullying? Is there a tuition teacher who's a problem? Is there a sick individual in the house? Always revisit the associated issues within the family and try and see if you can work on that, because it's very, very difficult for an ADHD child to regulate everything and filter it out. It becomes almost next to impossible. And then comes in your academic issues. Is there SLD? Is there something else related to the academics? Apply the rating scales, see the functionality, what is happening. Because most of what we call as non-responsive ADHD is actually not optimized ADHD, or ADHD with associate comorbidities or side effects, which we have not really looked into. It's unlikely that you would not be able to get a breakthrough if you revisit. Very labor intensive, but it can be done if you have flowcharts and you have a checklist of what you want to do and check at every point of the way, right? So Luke, sorry, this should have come earlier and I don't know how this came here, but anyways, leucovorin is was with all the other medication. That was the slide which was missing. Someone was asking me. So folate receptor, forget about that. So today what we have really looked at is the clinical prototypes of ADHD, how they present and how we approach them from a molecular point of view. The basic molecule pool that we have in the three-circuit model, common comorbidities seen. We reviewed our three pillars, which is methylphenidate atomoxetine as well as clonidine and their side effect, how to combine and when to switch. We glanced at other molecules also and the treatment in children below 5 years of age. And of course, if you hit so-called resistance, then you should think of changing, switching the molecule, or again, looking at combination or other factors which are there. So when we talk of precision in psychopharmacology, the knowledge that you need to have has to be combined with the art of looking for presenting symptoms and functionality for the children so that you can achieve what is best for them. And with that, I'll end. Thank you for giving me that little, quite a bit of extra time. And apologies for my pet. She just decided to be very responsive today.
So it was an excellent talk, Alka. Really engaging and clinically relevant session. What was particularly I appreciated was the way you moved beyond a symptom checklist approach and helped us understand ADHD through the lens of underlying neural circuits. And the discussion on matching specific symptom profiles with appropriate pharmacological interventions was provided really a personalized framework for treatment for each child. And your practical guidance on managing medication related side effects was equally valuable. As clinicians, we often encounter challenges not in initiating the treatment, but in optimizing it over time. Your insights on anticipating, monitoring, and addressing the side effects were extremely useful and will undoubtedly help us improve both adherence and outcomes for our patients. So thank you very much. I'm sure many are going to have a lot of questions. Now the question is, do we take them or
I think we've answered along the way. It's just one which has popped up saying that you can refer anyone for occupational therapy. But please remember one thing, until you get symptom control, occupational therapy is not going to penetrate. So we have patients who come to us who say, we have tried 3 years of occupational therapy, which we often advocate for children who are much younger, right? But they'll say they're little older kids, maybe 8 years, 10 years, who says, we've tried 3 years of occupational therapy, nothing is working. That's because um, you need to think of ADHD like a tube light with voltage which is not stable. It's flickering. And this is an example I often give patients, right? So when the tube light is flickering, is it going to give you its maximum output? It's not. No matter what I try. And that's what I'm trying with the occupational therapy. So first I need to plug in a voltage stabilizer, which is my medication. Once I plug in the medication, my therapy penetrates. And occupational therapy will work up to a particular age. You cannot expect someone who's 13, 14, 15, 18 to go to an occupational therapist. Then you have to think of other measures like sports, etc. Or monitor symptoms to decide response to medicine. You can have your checklists or you can have your scales. Is it safe to continue medication through several decades in moderate? Absolutely safe. We have children who have been with us from second grade till 12th grade. Now, what we usually do, if you're asking when to stop, is usually we tell the parents that if you want to take a break in 11th grade, in 11th standard, you can. In 12th standard, if depending on the curricular load and the child coming back to us, they may want to take it. But once they go into professional college, we teach them to take breaks themselves, mind breaks, and they learn to deal with their ADHD. They don't need to be on medication. However, we have a lot of ADHD kids who have gone into medicine, particularly, not so much engineering, who come back to us during the exams and say, please prescribe. We need it. We need it. Because you see, it's a demanding curriculum. You need sustained attention over a period of time. So you have to play it by the ear. But there's no problem in giving a child for even 10 years. We haven't seen any problems with that. Yeah, we got the monitor the symptoms, response to decide, response to meds. Again, you use your scales and your checklists as well as your monitoring of labs and other parameters. And I think it's 10 o'clock, so we should really wind up.
yes, definitely. Anybody from our committee wants to say something? Swati, Neha. Okay. Or else from the whole committee and from all of us, I really thank you, Alka, for this wonderful session. Hope we keep on learning more from you.
My pleasure, Kathy. Thank you again. Thank you, all of you,
Yeah.
for sustaining a